Assalamu alaikum everyone. This is Wania Shahid. I am a fifth year MBBS student and today I'll be going over ABG analysis with you guys. Now we already know that acid-base balance is very important in the body for it to function optimally. There are certain clinical presentations like shock, surgery and many others where this may be deranged, in which case the doctor suspecting this will order an ABG, which stands for arterial blood gases, where the blood is drawn directly from an artery. Now this is how an ABG strip looks like. It has a lot of details, but for ABG analysis we'll only be focusing on the pH, the partial pressure of carbon dioxide, the concentration of bicarbonate and some of the electrolytes. Before we get to the analysis, we first need to build upon our background knowledge. Now there will be a lot of details and tough concepts discussed here, but once we get a hold of them, ABG interpretation will feel like a piece of cake. Now we know that the normal pH of blood is between 7.35 to 7.45, and anything below 7.35 is called acidosis and anything above 7.45 is called alkalosis. But for interpretation we need to know the ranges of pH, partial pressure of carbon dioxide and concentration of bicarb. So we've already discussed the pH. In case you have difficulty remembering this, just remember that it's zero point 0.10 units. There's a 0.10 unit difference, so 35 to 45. And if you remember these two numbers, you will also remember the partial pressure of carbon dioxide because that's 35 to 45. The range of bicarb is 22 to 26. Now, especially for those people who will be doing calculations like in fifth year and in boards, you need to remember that you always consider absolute values, because if your patient is slightly acidotic or alkalotic and you're not following them up, then the pH may rise or drop further very suddenly and the patient may become critical. Hence, even minor changes need to be followed up. Now, in order to remember the absolute values, you don't need to uh, make such effort because they're basically just the average of the range. If you remember the range, you'll remember the absolute value. So for pH, it's 7.4, for carbon dioxide, it's 40, and for bicarb, it's 24. Now, let's get to the basic concept. pH is maintained by hydrogen ion regulation in the following ways. So there are chemical buffers, but we'll not be discussing that as it's not related to ABGs. But there are two very important systems that are very important for us to understand. First is the respiratory system. As we know, carbon dioxide is an acidic gas and the lungs are responsible for exhaling carbon dioxide. We can also say that the lungs are responsible for getting rid of acid. In the metabolic system, we know the kidneys are responsible for production of bicarbonate, which is alkaline. Hence, we can also assume that the kidneys are responsible for pumping in alkali into the body. Now, the respiratory and metabolic system play an important role in acid-base balance. They can also be held responsible for the derangements. The respiratory system could cause acidosis by retaining too much carbon dioxide, or it can cause alkalosis by exhaling too much of it. The metabolic system could result in acidosis by either excess production of acid or decreased production of bicarbonate. And it can result in alkalosis due to decreased acid production or loss or increased bicarbonate production. Now, there are different reasons and diseases responsible for each of these that you will understand when you read the book. Right now, we'll be focusing on what happens once a derangement has occurred. Whichever system is causing the initial derangement, the other system will try to counteract it in order to bring the pH back to normal. This process is called compensation, and it's very important for us to understand. Now, this is a flowchart that if we understand, we will understand the entire concept of ABGs. First, we need to look at the pH, whether it is low, normal, or high. Now, if it is low, we know a low pH is called acidosis. Now, this could be either because of the respiratory or the metabolic system. Now, for the respiratory system to cause acidosis, it needs to retain carbon dioxide. So, the partial pressure of carbon dioxide will be high, and we will call this respiratory acidosis. For the metabolic system to cause acidosis, it needs to pump out less bicarbonate. So the concentration of bicarbonate will be low and we will call this metabolic acidosis. Now let's say the pH is high. This is alkalosis. For the respiratory system to cause alkalosis, it needs to exhale most of the carbon dioxide out, causing a decrease in partial pressure of carbon dioxide, and we will call it respiratory alkalosis. And for the metabolic system to cause alkalosis, it needs to produce more bicarbonate, which will cause a high concentration of bicarb, and we'll call this metabolic alkalosis. Now, it's also possible for you to find a normal pH. It could be because there is no acid base derangement in the patient, or there is a mixed acid base disorder where there is acidosis and alkalosis which are neutralizing each other. So your pH will be normal, but your bicarb and your partial pressure of carbon dioxide will be deranged. So that will hint towards a mixed acid base disorder. Now, for compensation, we need to think of the two systems like friends. Any primary acid base disorder that alters one component will initiate a compensatory response that will alter the other component in the same direction. So, if one increases, so will the other. If one decreases, so will the other. Now, let's try to understand this through an example. If you see a patient who is presenting with drug overdose, like we've seen in movies, people who OD, they're not breathing, right? So, if a person is not breathing efficiently, they're not exhaling out carbon dioxide efficiently. Hence, they're retaining an acidic gas, which is causing respiratory acidosis. In this case, the kidneys will produce more bicarbonate to try to neutralize the excess acid. So as the carbon dioxide level increases, so does bicarb. Now the different scenarios can be understood through this table. Okay, so let's test our knowledge right now. If a patient is suffering from metabolic acidosis, it's acidosis, so the pH should be low. It's metabolic, so we know the primary disorder is in bicarb. For it to be acidosis, bicarb needs to be low. So what will be the compensatory response? If you said low, then you're right. Metabolic alkalosis. For alkalosis, pH needs to be high. For metabolic, we know the primary disorder is in bicarb. And for alkalosis, the bicarb will be high. What will be the compensatory response? Carbon dioxide will also be high. Respiratory acidosis. So for acidosis, we know the pH will be low. It's respiratory, so we know the primary disorder is with carbon dioxide, and for acidosis, the carbon dioxide needs to be high. So what will be the compensatory response? It will also be high. For respiratory alkalosis, we know the pH will be high. The primary disorder is with carbon dioxide, and for alkalosis to occur, it needs to be low. So what will be the compensatory response? It will also be low. So if you got the answers correct, then you have a very good grasp of this. And as you can see, there is a link between both of the systems. So if one increases, the other does as well. If one decreases, the other does as well. Now, if you are a first, second, or third year student, then this much information will suffice for you, as no one will ask you for calculations. But the following calculations need to be on your fingertips if you're a fifth year student. Another thing that we need to ascertain is whether the compensation taking place is sufficient or not. There may be another acid-base disturbance hiding underneath the primary one, in which we call a double disorder. For example, let's say there is respiratory acidosis, and we know for that carbon dioxide needs to be in excess. Now, to counteract this and neutralize the excess acid, the kidneys will produce more bicarbonate. But what if they're producing more bicarbonate than is needed for the neutralization process? This will leave us with excess bicarbonate in the body, and we will refer to it as metabolic alkalosis. So with the primary disorder, which was respiratory acidosis, there is also metabolic alkalosis. And in order to identify these double disorders, we need to do some calculations. Now, before we move towards calculations, we need to understand a certain concept. For a disturbance with metabolic origin, it's fairly simple, as the compensation will be carried out via the lungs, and it's a fairly quick process. There are changes in ventilation mediated by H plus sensitive chemoreceptors that are there in the carotid body and the lower brainstem, and thus the carbon dioxide exhaled is altered. But when there is a disturbance in respiratory origin and the kidneys have to compensate, it gets a little tricky, as the kidneys don't adjust as fast as the lungs do. Hence, we have a different expectation of compensation for an acute versus a chronic respiratory disturbance. All of these estimations are made using the following formulas. I would suggest you keep a calculator with yourself and pause the video if needed so that you can practice how to use these formulas. So for metabolic acidosis, we use the Winter's formula. It is pretty simple. To calculate the partial pressure of carbon dioxide, you multiply 1.5 by the patient's bicarbonate level and add it to 8. I've added examples so that you can practice using the formulas. Let's say the patient's bicarbonate is 12. You'll add it in the formula 1.5 multiplied by 12 plus 8 and you'll get the answer, which is 26. This one was fairly simple. Now metabolic alkalosis. Now to calculate the partial pressure of carbon dioxide, you multiply 0.7 with every 1 unit increase in bicarbonate. So let's say your patient's bicarb level is 30 and you know the normal bicarb level is 24. So when you subtract 24 from 30, you get 6, which is basically the excess bicarb, which is causing metabolic alkalosis. Now you multiply it by 0.7 and you get the answer 4.2. Okay, with the respiratory causes, how to use the formula, the process is similar. So I'll just be giving one example. So these are the formulas and I'll be using acute respiratory acidosis as an example. Now let's say your patient's PCO2 is 50 and we know that the normal PCO2 is 40. So the difference is 10, and as the formula says that you, with every 10 unit increase, you add 1 unit of bicarb to normal. So the normal value is 24, you add 1 unit and you get 25. So your patient's bicarb should be 25. Okay, so for these compensation formulas, don't worry, you don't have to remember them by heart. Just take a screenshot and save it in your phones so that you can use it in the wards. And slowly you'll get the hang of it. And especially in nephrology, you need to remember that we always consider absolute values. Now, specifically for cases of metabolic acidosis comes the question whether this excess acid is internal or external in origin. For this, we can calculate anion gap. The anion gap is a measurement of the difference or gap between the negatively charged and positively charged ions. It is calculated via the following formula. It is sodium minus chloride plus bicarbonate. The normal value is 12. And this is a very important step as it rules out a chunk of possible differentials. Now, I'm giving an example of serum electrolyte data so that you can practice it. Serum sodium is 135, bicarbonate is 7, and serum chloride is 98. What will be the anion gap? It will be 30. Now, as we know, this is elevated as the normal value is 12. We will call this high anion gap metabolic acidosis. This is helpful because it changes your list of differentials, but that you'll get to know once you're in 5th year. Now, if your patient is suffering from high anion gap metabolic acidosis, there's another step that you need to do. Basically, in our body, bicarb is a buffer. When we say a patient has high anion gap metabolic acidosis, it means that there is added acid in the body, and the body's bicarbonate buffers this acid. Hence, that is the reason it is decreased in the first place. So an anion of 30 suggests that we have added 18 extra units of acid to the body because the normal is 12. So 30 minus 12 is 18. 18 are the extra units of acid in the body. Now, the corrected bicarbonate is the normal expected value of bicarbonate in the body if there was no excess acid that was using it up for neutralization. If the value is more or less than expected, the expected value which is 24, we are dealing with another disorder. We can use the following formula to identify these added disorders, which is the formula of corrected bicarbonate, which is the measured bicarbonate plus the anion gap minus 12. So if this value is less than normal, then there is an additional non-gap metabolic acidosis. as the missing bicarbonate units are being consumed by another acid in the body. But if it is over the normal value, then there is a coexisting metabolic alkalosis, as it shows there are more bicarbonate units than normally should be. Now, let's say the patient's bicarbonate is 20 and the anion gap is 30. So what will be the corrected bicarbonate? It will be 38. As this is more than 24, which is the normal bicarb level, there is an added metabolic alkalosis. I hope this was helpful. Thank you so much, everyone.